Thanks to everyone for being here and participating in what I'm sure will be an extremely interesting, provocative, and most importantly, informative Cognitive Aging Summit. Naftali, I will let you take over. You're going to introduce yourself, and you can just stay seated and do everything from here.
Okay, thank you very much, Molly, and many thanks to all the organizers and to all people who invited us all here, and it's really a pleasure and honor to be here. My name is Naftali Raz. I'm from Wayne State University, and I will be chairing this session that has a very long name. How do we operationalize brain reserve, cognitive resilience, and compensation? Question mark. So without much ado, let's get the show on the road, and we'll start with one of the founding fathers of the whole concept of cognitive reserves, Yaakov Stern. So please, Yaakov.
Good morning. It's my pleasure to be here. I thank the organizers. A lot of the slides I'm going to show are ones that a lot of you have seen before, but I think my job is to try to set the stage, offer some definitions and some concepts that we can work on and discuss going forward. So the basic idea of reserve is that there are brain changes that occur that result in clinical outcomes, but as we now know, there's not a one-to-one mapping between the brain changes we can measure and the cognitive outcomes, cognition, et cetera. And the concept of reserve has been offered as a moderator, something that influences the effect of these brain changes on cognition. To my mind, I try to parcelate reserve into two buckets. The first is the idea of brain reserve. At first, it was a very passive concept of just more synapses to lose. And the emphasis here is on the brain hardware. We know a lot more about the brain hardware than we ever did before. But there are certain forces that allow the brain to be maintained. This concept of brain maintenance is a newer one. The idea of brain maintenance is that some of the same lifestyle factors that I'll talk about regarding cognitive reserve have now been shown to help maintain the brain. So the way I think about it is that the brain is maintained in a various way. At any one point, we have this amount of brain reserve, and the higher that brain reserve, the better someone's going to do in the face of brain changes. And then the concept of cognitive reserve emphasizes more the software idea, the resilience or plasticity of cognitive networks in the face of disruption. So those two things together, to me, make a nice package of interacting brain substrate and cognition to help people cope with brain changes over time. So this is a graph by Paul Satz. He was talking about threshold model. He introduced this concept of brain reserve capacity. And what he tried to show is if two people have differing amounts of brain reserve capacity, the person with less capacity cannot tolerate a lesion the way that someone with more capacity could. So the patient one can tolerate a lesion, not be below this functional impairment threshold, whereas patient two could not. It's a very passive form of an idea of brain reserve. More recently, this concept of brain maintenance has come forward. I think it's really an important one. The point, I think, specifically for cognitive aging, it's a really key point that the relative lack of brain pathology is the biggest contributor to heterogeneity of cognitive aging. And these lifestyle factors can contribute to that. So again, the way that I integrate that is that this brain maintenance can account for the current level of brain reserve, but I think it's really important because when we first started talking about these things, we did not realize how plastic the brain is, neurogenesis, changes in volume with experience, et cetera. And here's just a quick example of what I would call brain maintenance. Here's a longitudinal study of the size of the hippocampus over time. You have people with high LEQ. It's a measure of life experiences versus low. And you can see in this study, the people with higher LEQ were showing less change, less atrophy in their hippocampus than the people with lower life attainment. The cognitive reserve model I called it cognitive reserve because the concept of brain reserve was out there. So the idea of cognitive reserve focuses more on the hardware. So following up on Satz's diagram, we still have brain reserve capacity, but now imagining two people with the same underlying brain substrate. The idea is that one person can tolerate more of a lesion or brain change than the other because of the underlying software, the flexibility in coping with or adapting to these brain changes. You could call it reserve, you could call it resilience. I think we'll get into these terms as we go along. So what's the epidemiologic evidence for cognitive reserve? I'm doing this very, very quickly, but there's loads of epidemiologic studies that have looked for proxies for cognitive reserve, and I'll dwell on that in a couple of minutes. So proxies for cognitive reserve, such as premorbid IQ, education or literacy, occupational attainment, leisure activity, each of these have been associated with reduced risk of incident dementia, and separately. The evidence is more mixed, but there's enough studies to suggest that they can impact on the rate of cognitive decline in normal aging. And then a sort of counterintuitive concept is that people with higher reserve have a reduced risk of developing dementia or develop it later, but once it develops, there's a more rapid rate of mortality and cognitive decline. I always show this slide. My friends make fun of me. Molly told me that she showed it a long time ago in one of her first NIA talks. But the reason I show it is that I think it encompasses the three dimensions that you have to think about when you think about cognitive reserve. So here we have the three measures that I like. The clinical severity of Alzheimer's disease. Here we have education as our proxy for cognitive reserve, a life exposure. And we have xenon. This is before amyloid PET, or even this was a pre-FDG PET study, that is used to be a proxy or a measure for underlying brain pathology. And what the slide is showing here is you have three groups of 20 patients. There's a lot of other ways to do it with Alzheimer's disease, 20, 20, and 20, each carefully matched for clinical severity. And what it shows is that the people with the highest education have the most advanced pathology in that they have the most flow loss in the temporal parietal areas. This was the first study that I know of that put direct measures of these three things together and shows that education may actually help people look better clinically even though they have more advanced decline. Since then, this has been replicated with autopsy studies, et cetera. So my point is that in order to really study reserve, you need to put these proxies in the context. Just talking about education as a measure of reserve is very misleading. What we really want to talk about are how our measures moderate the effects of brain changes on cognition, and that's the only way to really get at the underlying problem. This is something that I think is a very interesting discussion that we've been having. This concept of brain reserve versus cognitive reserve sounds a little artificial in that we know that the brain is the underlying substrate for cognition. So really, should we make a separation like that? The reason that I did it initially is because the brain reserve concept was sort of a very passive concept, and I wanted to stress the active concept of cognitive reserve. And I think that it's still a useful thing to keep in mind. I think as we understand the underlying brain substrates, how cognition is mediated, I think we can think of models that actively combine the brain as we understand its organization and cognition. But I think that this distinction now is a very useful one. And the way I think about it now is that anything that you could see at an autopsy or with structural measures, I would put in the brain reserve bucket for now. The things that we have to, the networks that we really could never see on an autopsy level, that we need more functional measures like fMRI or EEG to look at, I'll put in the cognitive reserve bucket for now. You know, once you're convinced of the theory of cognitive reserve and epidemiology suggests to you that there really is such a thing, I think it comes down to, well, what are the mechanisms that underlie it? You know, so one way to say it is, well, how is reserve neurally implemented? And that's something I've been thinking about for a long time. I think that what I chose to use early on was functional imaging to look at it. Now, I have to say that was a choice that was really driven by our enthusiasm for fMRI and functional evaluation at the time. I think there's a lot of other ways to try to understand the underpinnings of cognitive reserve. One that I think I should really tout is more of a cognitive experimental approach, what are the cognitive mechanisms? Like, can we, if let's say I believe that people with higher reserve have more flexibility of solution strategy, can we really capture those things in a meaningful way using cognitive experimental approaches? But what I have here is sort of a schematic of how we've been thinking about the neural implementation of reserve, and I think it parallels a lot of other people's thinking, although the details might differ in different people's minds. So in this box up on top, we have task-related neural activity. We're challenging somebody with a task in fMRI, and what we see in the face of age-related changes or disease-related changes is often two different kinds of things. We might see a reduction in the efficiency or the capacity of the brain networks that underlie that process. And if the pathology or the brain changes are advanced, we might see compensation. That means different areas, different brain networks that are typically used start to step in. Now, that compensation could be helpful, or that compensation could represent a degeneration of the primary process. So compensation could be associated with better performance, or that compensation could be help people do the task, albeit at a worse state. I always say, like, the cane is compensatory. You could still walk, but not the way that you could using your regular capacities. And so in the context of this task-related activation, our proxies for cognitive reserve should moderate the effect of pathology on the brain, perhaps allowing people to maintain efficiency, allowing them to compensate, or if compensation is a bad thing, allowing them to not compensate for longer. And that's something that we paid a lot of attention to over the time and devoted a lot of effort to. The other interesting thing that I've been fixated on for a while is that beyond any specific task, we've seen that our proxies of CR, of cognitive reserve, moderate the effect of pathology or brain changes on performance, even after taking account the task-related brain changes. In other words, there's something else going on that the task-related fMRI does not capture that might be a global or more generic underlying set of abilities that cognitive reserve imparts. So what I'm going to do very quickly is walk you through a slide about efficiency and capacity, and then talk about this, what I would call task invariant reserve. So here's some recent data that we have. These are older people doing a set switching task. We're looking at the dual task condition, and in Alzheimer's, in healthy elders that are free of Alzheimer's pathology based on amyloid PET, what we see is these light green areas are the areas that are activated typically by young people and old people during performance of this task, or these parietal executive control areas. And what we find is that as people have higher IQ, we see a reduced activation of those areas, as if those areas are more efficient. And that's something that we've seen over and over again, that in the task-related areas, greater efficiency of these networks in people with higher reserve. In the presence of amyloid, what we found here is sort of cool. We found that there are other areas, not the typical task-related areas, but areas that typically deactivate, that now are activating a little more strongly in the people with higher IQ, as if these people are compensating. So it's just a very quick way of introducing you to the idea of efficiency, capacity, and compensation. Now, the original epidemiology tells us that people with higher education can actually cope with the underlying pathology longer before they're demented. Dementia is a multivariate problem. It's all kinds of cognitive activities and functions. So I've been very taken by this idea of finding what we would call a task-invariant cognitive reserve network. So to be very, very quick, this is work by Chris Habeck and just being submitted. What we did is we had 12 different activation tasks, and Chris sought out a covariance pattern, a network that was expressed in all of them, and that network's expression correlated with IQ. So what you have down here is a network. It seems to be a combination of some default mode areas and some task positive areas, but it can't be exactly the same, expressed covariant way. And so here's a common set of brain areas that are expressed in the same way, just no matter what the task is, as a function of IQ. And very interestingly, you can take that covariance pattern, go to some different people, different activation tasks, look at the expression of that network, and show that it does correlate with IQ somewhere else. And then most importantly, expression of this network actually imparts reserve, according to my definition, in that it moderates the relationship between cortical thickness and cognition, here fluid reasoning, such that as a function of expression of this network, people perform better or worse in the face of this cortical thickness. And I think that's a kind of test bed that we have to take our definitions of reserve, or our measures of reserve, and put it into. Does it moderate between the clinical changes, the brain changes, and the clinical changes? And what's really cool, I think, about this is a direct network that can actually be measured. So this is more of a direct measure of reserve, as long as it meets our concepts. So to sum up, I see I have 20 seconds, so it worked. I think that the epidemiologic and imaging evidence support this concept, and reserve is a theory. I think it's important to note that it's influenced by many aspects of experience in every stage of life. These are not definitions or measures of reserve. These are proxies that influence reserve. I've talked about the idea of brain reserve that might be supported by brain maintenance, and cognitive reserve, which is a more active process. I think that imaging studies can help us with this. I think we really have to agree on definitions of reserve and of test beds. Well, if I think that this is a network or a process or a function that imparts reserve, how can I test that and prove it? And finally, I think the key thing that we all are talking about these concepts, the reason we're talking about these concepts is that we have this intuition that if we can influence these processes, we can delay or reverse the effects of aging or brain pathology. So thank you very much for your attention.
We have time for questions. So if you want to ask a question, please step up to the microphone.
Hi. I have a question, because this is a cognitive aging summit. I have a question related to the cognitive tasks that are used in these studies. Because one of my concerns always with the concept of cognitive reserve is that we use the same neuropsychological tests and we use the same baseline measures to compare people who have higher education versus lower education. And I've always wondered if one of the issues is, are we giving the more highly educated people the right cognitive tasks? Are we challenging them cognitively in the same ways that we're challenging cognitively the lower educated, right? So I always worry that we use the exact same tools, cognitive tools, to measure cognitive performance, both in highly and
I understand what you're asking. So that's a real question, a real issue that we have to deal with. So, let's put it really in a very gross way. The epidemiologic evidence shows that people with higher education have a reduced risk of developing dementia. Right. Is it really that, or is it just that we're not challenging people with the right tasks? I think that people have tried to give more difficult tasks, maybe tasks that are more challenging to the people with higher education or IQ. But I think in the end, the evidence is that these people really just function and maintain abilities longer. So, is it just that we can't really test what's going on with these people? Or I don't think it's quite that. Where I thought you were going is, when we do these activation studies, are we giving the proper types of tasks in the context of activation that might elicit appropriate networks that are reserve related, and might those differ as a function of who the people are and the experiences that they have? I think that's also an important question to ask. Yeah.
Hi, excellent talk. I think the task and variant networks are really interesting. I was wondering if you've had the opportunity to look earlier in life, or do you think this is something that happens, late in life, in response to the accumulation of pathology, or do you think this is something that might be present, early and midlife?
Good question. So these networks were derived on people 20 through 80. But they're there in people in 20 as well as in people in 80. So a lot of what I think reserve is not a response to pathology. what I call neural reserve is just as a function of the life exposures that we have, how our brains work. How our brains now work in terms of the underlying cognitive processes. So yeah, these task invariant networks are there in young people as well. Do they change with aging? In our, it's really sort of fresh, but in our hands, it's the same network, but might be differentially expressed as people get older. But yeah, I think the point is that these differences in how people think, the underlying cognitive processes, develop along life. Now, when they're challenged by pathologies, that's when you can see them in action, but they're really there all along. Now, the compensatory processes might be specifically related to the challenges of age-related changes or disease-related changes. But yeah, these other networks, and this network in particular, is there in younger people as well. Yes?
But in looking at your slides and hearing her question, are there any assessments that would do some predictability?
So the question is, are there assessments that could help us predict who may be more resilient? Correct? I think so. I mean, that's where we're going. I think from an epidemiologic point, it's easy to say that, look, people who have more cognitively stimulating education, people who engage in occupations that are more cognitively stimulating, same thing for late life activities, social networks. So those are the kind of things that seem to be associated with reserve epidemiologically. Can we assess how much reserve someone has? That's a sort of a cool question. Let's say that we wanted to do an intervention and not just make someone better on a cognitive task, but impart reserve. I think the kind of task invariant network approaches that I'm talking about might be a way to directly do that.